Yeah, welcome to my channel. Today I'll be talking about D-Dimer. What is a D-Dimer? It is a protein fragment, meaning a tiny piece of protein that can be produced when the blood clot is broken down or it dissolves, a process known as fibrinolysis. Other possible names, when you go through the literature, you can find different names that will mean the same thing. Could be fibrin degradation products, fibrin degradation fragment, fragment D-dimer, or D-Dimer-E-Fragment. The D-dimer is not the type of parameter with which a definitive diagnosis could be made. Why that? It has low specificity. Can, however, indicate the presence of a clot, but not its location. So you can't tell with the value of the D-dimer that this person is having clots along the coronary artery, pulmonary, blood vessels, or the D-vein thrombosis. You can't tell yet, but you will know that there is clot somewhere. If the D-dimer is high, you then have to do more to make a definitive diagnosis. So it's a pointer. Still on D-dimer, if you have West score, and if it is low, then we have to get D-dimer down. I will have a separate presentation on West score later on. If West score is low and D-dimer is negative, you can rule out venous thromboembolism conveniently. However, if West score is very high and D-dimer is low or intermediate, you cannot ignore that. You must treat as venous thromboembolism. Let me repeat. If you have carried out your West score and it's very high, regardless of what the value of D-dimer is telling you, you must treat as venous thromboembolism. That is DVT progressing to pulmonary embolism depending on the presentation. Now the background here is that D-dimer was introduced in the 70s, but was not yet welcome worldwide or not being incorporated into the medical diagnostics process until 1990s. Mostly done when suspicious of venous thromboembolism or when you are trying to classify disseminated intravascular coagulopathy. You then call for D-dimer. Mostly, high values may be due to other conditions, and I will go into that in a bit. High value is an indication for more investigation or investigations to have a definitive diagnosis made. D-dimer formation. Clot formation starts either by intrinsic or extrinsic pathway. The intrinsic pathway involves the clot formation within the vascular system. When clotting factors 8, 9, 11, and 12 are activated by the platelets and endothelial exposure to collagen. The extrinsic pathway involves the activation of factor 7 by tissue activating factors when there's a cut or external force. Both pathways, that is intrinsic and extrinsic, will form common pathway when they meet to complete the clotting process using factors 1, 2, 5, and 10. Then, the thrombin will later convert fibrinogen to fibrin. The formed fibrin will aggregate into protofibrils. Factor 13 will then cross-link the fibrin protofibrils at the D fragment site. That will lead to the full clot. Still on how the D-Dimer is being formed, plasmin will then later act as a fibrinolytic agent to break down the insoluble fibrin into higher molecular weight polymers. Plasmin will further break down the polymers into intermediate ones. The journey is not finished yet. There will be further plasmid breakdown, and that will end up with smaller polymers known as fibrin degradation products. When you see D-dimer in the plasma, then you should know that coagulation must have already taken place. And then that must have been as a result of thrombosis somewhere or DIC. But many other conditions are responsible. So we'll go over that later on. The structure could be either a 180 kDa or 125 or 340 of 2D domains, or molecule of 2D domains and E domain of the original fibrinogen molecule. So different structures, but the clue here is that when you see D-dimer in the plasma, then the coagulation system must have been activated. And we must be dealing with thrombosis or DIC somewhere. Is it venous thromboembolism? Is it DIC that is not classified yet? But the truth here is that not only under those two conditions that we can find D-dimer. Now, who should have D-dimer acid test done? Who? When there's positive family history of venous thromboembolism or the patient is down with DIC right now, go for D-dimer assay. Patient with leg pain or leg swelling, D-dimer to rule out DVT. Chest pain of unclear etiology, have D-dimer to rule out any thrombus formation somewhere. Cough and shortness of breath, want to rule out pulmonary embolism from DVT, you can have D-dimer done. In dyspnea, palpitation, or patient on combined oral contraceptives or hormone replacement therapy, you can have D-dimer done. And now in the era of COVID-19, you can have D-dimer done. Okay, COVID-19. And also in community-acquired pneumonia to determine prognosis, because patients with community-acquired pneumonia with a high level of D-dimer will have poor outcome. Now, high values without venous thromboembolism. Yes, that is possible in COVID-19, in liver disease, in trauma, in malignancy like leukemia, in pregnancy, in rheumatoid disease, in infection. Now it could be like COVID is an infection, pneumonia, flu, and so on. High value is also possible without venous thromboembolism in syncope, in CPR, in stress, that is physical stress or mental stress, in hemodialysis, in heart failure, in streptokinase use or recombinant tissue plasminogen activator. As an indication of high mortality in community-acquired pneumonia, D-dimer value that is very high could be from all of this. Now, when it is COVID-19 and D-dimer, if it is raised 4 times, fourfold of the normal level, and the individual is having COVID-19 or you are not sure, then do COVID-19 testing immediately. Not COVID-19 screening, testing should be done now. If COVID-19 comes out to be positive at this time, then we're in trouble. because the mortality is likely going to be very high. In case of false negative, it might be because sample has been taken too early after thrombus formation, or testing is delayed for several days. Then patient is already on anticoagulant. If patient, that history must be taken. If the patient is on anticoagulant before D-Dimer is taken and the result comes out to be false negative, then it's because of the anticoagulant. More anticoagulant in the collecting blood compared to the blood will give us false negative. The normal ratio should be 9:1 of blood to anticoagulant. But when the value of anticoagulant is too high, then we'll be in trouble. We'll have false negative. Other investigations that you can do to lead you to specific diagnosis is variable, in the sense that it depends on what the clinical presentation or presentations is or are. If there is nothing leading to no suspicion of pulmonary embolism, you may not bother about ventilation perfusion scan. If it is related to the heart and you are not sure, you can have echo, cardiac enzyme, Doppler ultrasound, EKG done, CT angiography, chest x-ray, and if you are not yet sure, if you are out of cardiopulmonary system, you can rule out what is happening with the liver function test, thyroid function test. You can also have complete blood count done. And remember, I've just gone through COVID-19 and D-Dimer value is likely going to be high in COVID-19 infection. And when it is, it's a bad sign, poor prognosis. Abdominal ultrasound could be done because we want to know what is happening to the pancreas and so on. You can have antibodies, polymerase chain reaction, everything done to know what's happening to various viral infections. You can have blood culture in case of suspicious of bacterial infection. And don't be deceived, have pregnancy test done. This time around, it's not qualitative, it's just yes or no test, beta macrochronic gonadotrophy, just to be sure the woman is not pregnant. And suspected etiology will determine other investigation or investigations you will embark upon. Now, when you reach lab and it is about D-Dimer, it is better to have enzyme-linked immunosorbent assay done. That is preferable when it's compared to latex agglutination test. Then, you can take history of streptokinase or recombinant tissue plasminogen activators used. And of course, rule out if this patient had already taken anticoagulant before this sample has been taken, because that will alter the value. Now, because we knew D-Dimer to be assayed most of the time when we are suspecting venous thromboembolism, that is DVT, progressing to pulmonary embolism, or we are dealing with DIC, and then we want to classify it. So I'm going to dedicate the remaining period of this presentation to go over venous thromboembolism risk factors. DVT must first occur before pulmonary embolism in venous thromboembolism. The clot forms in the deep vein in the leg. That is why I said who should have D-Dimer assay done? Someone with leg pain or leg swelling. Yes, DVT. The clot can break and travel to the lungs, where it can cause an acute life-threatening condition known as pulmonary embolism. I'm laying emphasis on this because pulmonary embolism could kill very fast. Venous thromboembolism is very common amongst hospitalized patients or few months after being discharged. Now, I will go over risk factors for venous thromboembolism. It is worse in surgical department, intensive care unit, stroke, myocardial infarction, old age, previous venous thromboembolism, immobilization, renal failure, hypercoagulable states. Other risk factors for venous thromboembolism will include genetics, that is, familial or hereditary, factor V laden, protein S deficiency, protein C deficiency, antitrophin deficiency, malignancy, surgery. Others include orthopedic procedures, mobilization, pregnancy, oral contraceptive pills, hormonal replacement therapy, antiphospholipid syndrome, polycythemia vera, essential thrombocytopenia, and tamoxifen. The list includes trauma, heart failure, congenital heart disease, inflammatory bowel disease, nephrotic syndrome, paroxysmal nocturnal hemoglobinuria, and liver disease. Still on, the risk factors for venous thromboembolism will include medications like thalidomide, lenalidomide, asparaginase, procedures like central venous catheterization, prolonged sitting or long flying, like from across the Atlantic or across the Pacific, protein mutation, plasminogen deficiency, dysfibrogenemia, that is alteration in conversion of fibrinogen to fibrin. Others will include air pollution, renal transplantation, heparin-induced thrombocytopenia, microalbuminuria, hyperhomocystinemia, varicose veins, and inferior vena cava anomalies. The list will include Paget-Scrotal syndrome, May-Turner syndrome, and it could be seasonal because it's going to be more in winter time, polycystic ovarian syndrome, sepsis, obstructive sleep apnea, and obesity. Now, finally, on risk factors for venous thromboembolism will include anemia, Klinefelter syndrome, chronic psoriasis, asthma, particularly those that will be on oral or intravenous steroids for a long time, vasculitis, active tuberculosis, intravenous drug use, glucocorticoids, and smoking. I know someone would have said you should have put smoking first. Well, putting it last means is also very significant so that you don't forget that smoking. Now, finally, Paget-Scrotal syndrome is a form of upper limb thrombosis secondary to thoracic outlet obstruction, while May-Turner syndrome is compression of the left common iliac vein causing left iliofemoral DVT. You can check my channel for separate presentation on each of these. I have Paget-Scrotal syndrome and May-Turner syndrome fully presented and published right here. Okay, now finally, D-Dimer could be a clue to a big problem, but sometimes might not be, as a result of big problem. Whichever way, once you have D-Dimer done, let there be conclusion on the cause or causes. With that, I've come to the end of this very presentation. Thanks for listening. Remember to share. Remember to subscribe to my channel so that you can have all my presentations immediately they are published. I appreciate it.